Welcome. I hope this finds you in good health. I am dietitian Gilbert Gaston Charles, a clinical dietitian respectively, and as of today, we'll see about the medical nutrition therapy in CKD. This is one of the presentations I made in one of the webinars, so if you missed this webinar, then this is your opportunity to explore through the medical nutrition therapy in CKD. And our contents will be much on understanding the CKD, its progression, and so forth, but also nutrition standard operating procedures in CKD, drug nutrient interactions that rise up in management of CKD patients on medications, and also the diet planning process in CKD. The prerequisites of this session, mostly what a person should really know, is the kidney anatomy and the kidney physiology. You should know the location of the kidneys, the arteries, the veins taking the blood from the kidney, and the arteries supplying blood to the kidneys, but also the full anatomy, functionalities, and the physiology of the kidney, meaning with the fluid balance, electrolyte balance, the RAS mechanism, and everything, the hormones that are all associated with the kidney, and everything with the kidney. That should be the prerequisites of a person really need to engage better in this session. So starting with the part one, as we said it before, understanding chronic kidney disease, CKD. We'll see about the epidemiology, the causes, the stages of CKD, the diagnostic criteria also, without forgetting the definitions. So what is chronic kidney disease, abbreviated as CKD? This is a progressive condition. Meaning progressive, it starts with a certain stage, maybe stage 1, stage 2, stage 3. It keeps on increasing its severity until it reaches the end stage. That's why we say it's a progressive. It comes from a little non-asymptomatic condition to the symptomatic conditions. But also it is nicknamed as a silent killer. Why a silent killer? Because a person developing CKD, at first place, they might not know that they're suffering from CKD until they are being diagnosed with it. And it may not come with specific symptoms at first time when developing from stage 1, stage 2, stage 3. People mostly start experiencing these symptoms at stage 3. Whereas in stage 1 and stage 2, most of the people believe that they are really, really normal. So CKD is defined as a kidney damage or an EGFR glomerular filtration rate of less than 60, persisting for 3 months or more. This is something very important to note, persisting for 3 months or more, irrespective of the cause. The causes can be it can be diabetes, it can be hypertension, it can be other kidney diseases themselves, like glomerulonephritis, nephrotic syndrome, which can also lead to progression of this CKD. So if the person has this EGFR of less than 60 for persisting for 3 months or more, we're more likely to diagnose this patient with CKD. It is a major public health concern affecting millions of people worldwide, and also it is associated with very high morbidity and mortality and health costs. So dealing with the epidemiology part of the CKD, how far are people suffering from CKD? How many people has it affected? And a lot of it, 10 to 15% people globally suffer from this CKD. This means above 800 million people are having this CKD. But also 14% of sub-Saharan countries, the population of the sub-Saharan countries, they have this CKD. And it is more prominent in urban areas as compared to rural areas. But also, being more prevalent in urban areas, it can be associated with the accessibility to healthcare to healthcare facilities. So it may have a lot of factors contributing to why we have more CKD cases in urban areas than rural areas. This cannot rule out 100% that rural areas people do not have CKD. But also, according to WHO, 1 in 10 adults have CKD. So, chronic kidney disease affects 1 in 10 people. And this, could it be you? So, this is a question that you need to ask yourself. Could it be you? 1 in 10 people. Could you be that one person suffering from CKD and yet you do not know that you are suffering from CKD? What thing should you do? Go for screening. Go screen your kidney function tests. Well, it is more common in older adults, especially the 60s years and older. It is the high prevalence is in women mostly. It may be associated with many factors, but also associated with hormonal influences and differences in the two genders, men and women. But also 9 out of 10 CKD people don't know yet if they have it. So if we have one person among 10 with CKD, we have 9 people with CKD, of whom out of 10 they do not know that they have this CKD. So it is very important to go for screening of your kidney functions before it's too late. When you're in stage 4, that's when you know that you have CKD. 12% of CKD patients progress to end-stage kidney disease. So we have different causes and risk factors for CKD with the primary causes and the secondary causes. So starting with these primary causes, we have diabetes mellitus. 30% to 40% of diabetes patients, they progress to CKD. It is the leading cause of diabetes mellitus is the leading cause of this CKD. This is due to diabetic nephropathy, due to inflammation of the high blood sugar that can affect the kidney functions, and at the end of the day, developing CKD. The second cause is hypertension. 20 to 30% of CKD causes are caused by hypertension. So high blood pressure damages kidney blood vessels, leading to nephrosclerosis. Glomerulonephritis, this is the inflammation of the glomeruli due to autoimmune diseases such as lupus, infections, or genetic factors. So all of these, they tend to affect the functions of the kidney, of which at the end of the day lead to progression of this CKD. We have the polycystic kidney disease. This is a genetic disorder whereby there is a formation of cysts in the kidney, and these impair the function, and they vary according to the severity of the cysts that have been formed. But also we have obstructive uropathy. This is the blockages of the urine due to kidney stones and large prostate, causing the urine backflow, which damages the kidney. But also we have a lot of cases with cervical cancer leading to obstructive uropathy, at the end of the day leading to CKD, and it may progress to end-stage kidney disease. The secondary risk factors are like obesity, smoking, the chronic use of non-steroid NSAIDs, but also the infections, recurrent UTI and hepatitis, environmental factors like exposure to heavy metals like lead, mercury, and cadmium. Mostly with the people working in the mines using mercury to purify metals like gold. This really affects these people working in those areas. So it is an environmental factor which predisposes people to kidney injury, leading to chronic kidney disease. Overdose from local herbs. This is experienced from the clinical grounds. The social determinants like poverty, limited healthcare access, and low health literacy also leads to this CKD. What is the proportion of the causes of CKD? We have this pie chart showing 29% of 29% of CKD is caused by high blood pressure, 44% from diabetes, 18.4% other causes, 7 glomerular diseases, and 1.6% polycystic kidney diseases. As you can see, just as how I said, 30 to 40% of diabetes patients develop the CKD, but also 20 to 30% of hypertension patients contribute to CKD, just as more approximately with the pie chart presentation here. Now it's time to understand the stages of CKD. We have the stage 1, stage 2, up to stage 5. CKD is classified into 5 stages based on glomerular filtration rate and evidence of kidney damage, whether it be proteinuria or imaging abnormalities, especially like the polycystic kidney diseases, can be seen through the imaging. So, starting with stage 1. At stage 1, a person may have normal GFR, and this can be 90 mils per minute per 1.73 meters square or above, with kidney damage evidence, either proteinuria. One of them can be there. It is often asymptomatic and detected through lab tests mostly. Stage 2, we have a mildly reduced GFR, 60 to 89. And this is also associated with kidney damage. Mild symptoms may appear like fatigue. And so at these first 2 stages, stage 1 and stage 2, a person might not clearly identify themselves as they have this kidney disease unless they go for screening. Stage 3A. So stage 3 is divided into stage 3A and B. Stage 3A, GFR is around 45 to 59. At this time now, the person may have these symptoms: hypertension, secondary to CKD, edema, and anemia. At this point is when a person now, they can say they feel that they are having something different going on in their bodies. They're getting more weak, they're getting edema, they can be aware of the heartbeats, and all these changes can make a person now to go to the hospital or a health facility to be sure of their health. This is why we say it's a silent killer. Reaching at stage 3, a person still not knowing if they're truly having a kidney disease or not. This really affects the management of CKD in early stages. At stage 3B, the GFR is 30 to 44. Symptoms are more pronounced and complications are increased at this stage. Stage 4, we have severe reduction of GFR, which ranges from 15 to 29. At this point is where we prepare the patient for dialysis and transplant. While stage 5, defined as kidney failure, with GFR less than 15. And patients at this stage need dialysis and transplant for survival. So what are the diagnostic criteria for CKD? When do we say that this patient has CKD? As we said earlier, a decreased GFR of less than 60 in 2 occasions within 90 days range, that's 3 months and more. But also having albuminuria greater than 30 milligrams per gram with the albumin-creatinine ratio of 30 milligrams per gram or greater. But also urine sediment abnormalities, having froth in urine, a lot of froth, the urine forming fluids. That should be one of the ways a person should, or a criteria that you should use to identify if a person has CKD. Electrolytes and other abnormalities due to tubular disorders, abnormalities detected by histology, but also structural abnormalities detected by imaging, and history of kidney transplantation. So in the comment section, you can share your idea with how can I improve my GFR. So how can you improve your GFR? Let's say you're in stage 2 of CKD. Tell us how can you improve your kidney GFR. That's a point of discussion, part 1. So our part 2 is nutrition standard operating procedures in chronic kidney disease. We'll see the effective nutritional screening, assessment, and intervention. The first thing about screening is that you should use a subjective global assessment tool. This is a comprehensive tool involving clinical history, physical examination, and subjective assessment of the patient's nutritional status. It is highly recommended for CKD patients by Kidoki. So let us see the components of the SGA tool. The first part, the medical history part. It takes the recent weight changes, changes in dietary intake, gastrointestinal symptoms, the functional capacity, and disease-related metabolic demand. It is very important to have a record on the recent weight change, but also the dietary change in dietary intake. Patients with CKD often present with reduced appetite, reduced dietary intake, gastrointestinal symptoms they have these epigastric pains, but also the gastritis, of which can be induced by excess toxins collection in the body, but also reduced functional capacity of the body, and disease-related metabolic demand can be higher. Physical examination part of the SGA tool. We have signs of fat and muscle wasting. We'll have this. You can download this. I think it is very available in the internet, the SGA tool. The physical examination part deals with the trying to see the signs of fat and muscle wasting, but also nutrition-related fluid balance changes. How often does the patient get urine? What is the amount of urine that the patient gets? We have different clinical manifestations, whether the patient is wasted, malnourished, has edema, and so forth. So the important parameters, anthropometric parameters in while assessing your patients with CKD. Number one is the weight. Usual body weight of the patient. You should know the usual body weight of the patient. You should know the current body weight of the patient. What is the current body weight and what is the usual weight of the patient? Understand to how far is the current body weight different from the usual body weight of the patient. But also the post-dialysis body weight. Most of the times it's a challenge because some post-dialysis physicians do not record the post-dialysis weight, of which a dietitian needs to use this weight in estimating the requirement, the dietary requirements of these patients on dialysis. But also you should know the adjusted body weight. This is when the dialysis the post-dialysis weight is less than 95% or greater than 115% of standard median weight, of which the standard median weight can be found in the NANES 2-weight chart. So the formula for having an adjusted body weight, we have the adjusted body weight equals edema-free body weight plus the subtraction or the difference between standard body weight and the edema-free body weight multiplied by 0.25, as you can see right there. So I hope that formula really explains itself and you can use it in managing your post-dialysis patients. Other important parameters are fluid weight assessment for edema, the waist circumference, the waist to hip ratio, the skin folds, body frame size. This can be using the 18 centimeter divided by waist circumference. Frame sizes are very crucial in determining the caloric requirements. So we have the small, medium, and large frame size. The larger the frame size, the higher the caloric demand or caloric requirement of the patient. We have important biochemical parameters like the blood urea nitrogen, creatinine, potassium, sodium, hemoglobin, calcium phosphate, prothrombin hormone, hematocrit. It is important to consider the institutional ranges and classification of biochemical parameters because you're not yourself as a dietitian, you have other health professionals with you. So this is a chart of normal blood parameters, of which you should also have a reference from your institutional references. So you should not rely on this reference that I have provided here. This is just for a presentation here. So on clinical evaluation, evaluate the 24-hour fluid balance using the subjective global assessment tool. Check for signs and deficiencies of and symptoms of different vitamins, but also signs of protein energy wasting. Check for them. Record the temperature and blood pressure. Evaluate the appetite, nausea and vomiting, but also edema assessment. In dietary history taking, be smart at dietary history taking. Go beyond food knowledge. Yeah, I think that was a typing error somewhere with the word knowledge. So use 24-hour recall, use the food frequency questionnaire, use a 3 food day record on dialysis and non-dialysis days, but also dietary analysis using 24-hour urine collection for calcium and potassium and other biomarkers. The nutritional requirements in CKD. We start with the protein. Protein requirements, mostly the protein requirement should be with high biological value protein, greater than 50% of the protein that you're providing to your patient. These patients, mostly, they are at risk of protein energy wasting or protein energy malnutrition. So we have the pre-dialysis non-diabetic patients or with CKD stage 3 to stage 5, whereby the protein requirement is a bit lower if the patient is not on dialysis, 0.55 to 0.6. This is according to Kidoki. But also hemodialysis or peritoneal dialysis patients who are stable, the protein requirement may range from 1.0 to 1.2 gram per kg. So you will have to see the metabolic demand of your patient so that you can estimate the protein requirement per day, because you see there are ranges, so you should know at what range your patient really falls on. We have the hemodialysis and peritoneal dialysis patients who are acutely ill. These will require a higher protein requirement, with the least being 1.2, while the patients on a conservative management with ranging from 0.6 to 1 gram per kg per day. And transplant high dose patients on high dose of steroids, their protein requirements are also higher as compared to transplant low dose steroid patients. The fat requirements. In most conditions, kidney fat requirements are to be maintained at 30 to 40% of total energy requirements, while the cholesterol intake should be maintained at less than 300 milligrams per day. You should always employ the use of these the kidney or renal diet exchanges so that you can have the actual amount of cholesterol intake per day for the patient, so that you may avoid overfeeding the patient. But also we have carbohydrate requirements, which should be maintained at 50 to 60% of the caloric or energy requirements per day, with optimal complex carbs. Should be optimal, the complex carbs, because providing more complex carbs may lead to these high phosphate levels also. In fiber, requirements should be maintained at normal, of which is 20 to 25 grams per day, and the calories requirements, you may see the range, it ranges from 30 to 45 kilocalories per kg per day, but also it is very important to be specific with the patient's BMR, stress level, and activity factors consideration. This is using the Harris-Benedict equations and other equations of energy calculations or estimations, so that you can have the best energy requirement estimation for your patient per day. We have other minerals requirements, of which should be maintained at certain levels, such as in different conditions, sodium, potassium, phosphorus, calcium, in which you can see in pre-dialysis, the sodium should range from 1,000 to 3,000 milligrams per day, while in potassium, it's 1,500 to 2,700. The phosphorus, less than 10 milligrams per kg, while calcium is maintained at 1,000 to 1,500 per day. So we have this chart, and it can be useful for a dietitian or a nutritionist while planning the diet for their renal patients, whether on dialysis or not on dialysis or conservative kidney management, and so forth. The vitamins also should be supplemented according to deficiency risks, especially the D vitamin, the B complex, the vitamin C, E, K. You should always provide supplements when there is deficiency or increased risk of deficiency. We have the prothrombin hormone issue in CKD patients, whereby the prothrombin hormone levels may rise higher, leading to demineralization of the bones, and these patients will present with weak bones, of which can be easily to fracture. This is due to the reduced vitamin D activation process, which is linked with the kidney itself. So if we do not have active vitamin D in the body, so we can have low calcium levels in the body, which the body with the homeostasis mechanism or the feedback mechanism of the body is by secretion of PTH hormone in high amounts, of which leads to demineralization of the bones. So these patients may require vitamin D supplementation and calcium supplementation, but also while you provide calcium supplements, you should be aware with the of which excess calcium can lead to calcification of the soft tissues. The fluid requirements also are different according to different levels or different managements that the patients are receiving. We have the pre-dialysis patients, on which the fluid requirement may range, you take the output plus 500 to 750 mils per day. But also on the patients on hemodialysis, we have the peritoneal dialysis patients, the ARF, the nephrosis patients, and transplant patients. So our point of discussion, this is the second point of discussion. Tell us about the moment you requested for a lab result to be sure about your nutritional goals and objectives as a nutritionist or a dietitian. So I think you'll share this in the comment section part. Our part 3 is the drug-nutrient interaction in chronic kidney diseases. We're going to see the medications in CKD and nutrient considerations, especially in patients with having medications with CKD. So what is drug-nutrient interaction? A drug-nutrient interaction occurs when a medication affects the absorption, metabolism, or excretion of a nutrient, or vice versa. So the nutrients can affect the metabolism of the drugs, or the drugs can affect the metabolism of the nutrients. So that's all how it goes with drug-nutrient interaction. So we have the types of drug-nutrient interactions, the DNRs. We have the pharmacokinetic, of which is the altered absorption, such as phosphate binders reducing ion absorption. While we have also the pharmacodynamic nutrient interaction, of which is the nutrient altering drug effect. Example, high potassium foods with ACE inhibitors. So all of these is the drug nutrient interactions happening during provision of medical support to CKD patients, while at the same time they need nutritional support. So the impact of drug nutrient interaction can be malnutrition or toxicity of drugs and reduced drug efficacy. So the common medications in CKD and their nutrient interaction. We have the phosphate binders like calcium carbonate and cevilamine. These bind dietary phosphorus but may reduce absorption of fat-soluble vitamins such as vitamin A, D, E, and K. So if the patient is on phosphate binders, it is very important to assess for signs and symptoms or deficiencies of these vitamins, the fat-soluble vitamins. We have the diuretics like furosemide. This is very popular. These increase the excretion of potassium magnesium, and B vitamins. This is why you will find most of the patients who are having furosemide, they may present with hypokalemia, especially in these patients with the CKD patients on dialysis. So you should supplement these patients with B vitamins and see how you can manage the dietary intake of potassium. We have the ACE inhibitors like racinopria. These they increase the risk of hyperkalemia when combined with high potassium foods like bananas and oranges. So if your patient is having these ACE inhibitors, angiotensin A converting enzyme inhibitors, these patients are at risk of hyperkalemia when you provide high potassium foods. So we're going to see a list of foods also that can be reduced or restricted in CKD patients, but also of which may favor the condition of the CKD for a better progress. If the patient is on proton pump inhibitors like omeprazole, these reduce the absorption of B12 vitamin, magnesium, and iron. You'll find most of the kidney patients having anemia, of which having anemia will also lead to even reduced function of a further reduced function of the kidney, of which is the function that is remaining, or the residual function that has remained. So it is very important to have supplementation of iron and B12 in patients with proton pump inhibitors, but also assess for signs and symptoms of the deficiencies of these vitamins and minerals, so that you can have a more personalized prescription. We have the erythropoiesis stimulating agents like epoetin alpha. These require adequate iron intake and folate for efficacy. So if we give this patient with, we provide epoetin alpha to these patients, and they do not have a high intake of or an adequate intake of iron and folate, will not be doing any work, because these patients will still present with anemia every time they come to the hospital. But also we have nutrient specific interactions in CKD. Like high protein diets may increase uremic toxins, and also some drugs like corticosteroids increase protein catabolism. So if the patient is on corticosteroids or high dosage of steroids, it is very important to increase the protein intake of the patient, as you saw in the previous chart of the protein requirement for transplant patients on high dose of steroids. Potassium, we have risk of hyperkalemia in combination with ACE inhibitors, ARBs, and potassium sparing diuretics. Phosphorus, phosphate binders reduce the absorption of phosphorus, just as how I've seen previously. The fat-soluble vitamins, these are at risk with reduced absorption with binders or bile acid sequestrants. And also water-soluble vitamins, dialysis removes the B vitamins. Supplementation may be highly needed in dialysis patients. So the take-home note on this part of drug-nutrient interaction is timing of medication and meals. Phosphate binders must be taken with meals to bind dietary phosphorus. Avoid taking iron supplements with calcium-based binders. But also the potassium restriction, limit high potassium foods such as avocados, spinach, bananas, in patients on ACE inhibitors. So it should be specific. When your patient is at increased risk of high potassium levels, that's when you do these restrictions. So our point of discussion, this is point 3 of discussion. What more drug nutrient interaction in CKD do you have to share? You can share on the comment section or on the more drug nutrient interactions in CKD. Well, this is our last part now, the part 4, diet planning in CKD. At this part, we'll understand CKD specific dietary needs and how to use the food exchange system for meal planning. So the key nutrients that we monitor in kidney patients are protein, sodium, potassium, phosphorus, and the fluids. So we're going to see about all of this. The goal for CKD diet planning is number one, maintaining nutritional balance while limiting kidney workload or overload. But also our main goal, another goal, is controlling the blood pressure and fluid retention. This means we'll need low sodium, but also preventing electrolyte imbalances, limiting the potassium, phosphorus, but also you should also have in mind the drug-nutrient interaction that may occur. But also to manage protein intake and to reduce uremia without causing malnutrition. That is very important. You should be aware of the patient, whether the patient is on hemodialysis, peritoneal dialysis, or is on conservative kidney management. All these ranges of management, they have different protein requirements, but also to support overall health with adequate calories and vitamins. So, food choices in CKD. We have the foods to include and the foods to avoid or limit. The foods to include are low potassium fruits. Example, the apples, berries, and grapes. These are low potassium fruits that can be included in the diet of your CKD patients. Low phosphorus proteins, egg whites, chicken, or just skinless also. Low sodium options, like fresh herbs and salted spices. Well, there are a lot of options. Of course, you can have them, and you may also share them in the comment section part, because I'm just giving a glance of what should be done. And refined grains, if phosphorus restricted on phosphorus restricted patients, like white rice and white bread. So avoid or limit high potassium foods like bananas, oranges, potatoes, but also it should be specific according to the potassium levels and other parameters. High phosphorus foods should also be avoided or limited to according to the patient's the way the patient presents with the blood markers or the biomarkers. The dairy, nuts, and beans. Processed foods should also be should be limited completely. Like the canned soups and deli meats, but also whole grains if phosphorus restricted. If the patient is phosphorus restricted, then you should also avoid whole grains, because whole grains may increase the risk of having this hyperphosphatemia. So now, using the food exchange system in renal diet planning. We're not going to dig deep into this exchange system, because it really needs a lecture of its own or a session of its own. So this part, you should be able to use the food exchange system for renal diet planning. So to use food exchange system for diet planning, you need to have calculated macronutrients, requirements, and micronutrients target or intake and control. So what is food exchange system? This is a tool to simplify meal planning by grouping foods with similar nutrient content. It helps control portion sizes and nutrient intake. This in terms of potassium, the protein, the phosphorus, and other nutrients. So the categories included in food exchange system. For normal people or the other normal cases, we have the milk, which can be skimmed or whole milk, vegetables, fruits, sugar, legumes, starches or carbs, and protein and fats. While in renal exchanges are even subdivided. We have like you can see the vegetables part. We need to see the low vegetables, the low potassium vegetables, moderate potassium vegetables, and high potassium vegetables. In fruits, the same, but also a further subdivision is done in the starch part, where we have the low potassium starch and high potassium starch. In the protein, we have the low phosphorus protein and high phosphorus protein. So you should be very sensitive while dealing with the renal patients, because they are sensitive to numbers, sensitive to how high sodium is, how high potassium is, and how high calcium or low phosphates are in the body. So each exchange in renal exchange equals a standard amount of calories with protein and carbs and other nutrients within. So you can see a good example is milk. One serving of milk in renal patients, it's half of a 250 ml cup, of which has 10 grams of carbs, 4 grams of protein, 5 grams of fats, but also 110 milligrams of phosphorus, 65 grams of 65 grams of sodium. So all of these exchanges will help you to know how many servings of a specific kind of food can your renal patient take, whether on dialysis or pre-dialysis or on a kidney conservative management process. So what a serving really looks like when you're dealing with serving. You should have a picture of what a serving looks like when you're planning diet, and not specifically for renal patients, but this is to all patients. You can see like a vegetable serving, what it looks like. You can see the half cup of broccoli, what it really looks like, half cup of squash, what it really looks like, and half cup of carrot, what half piece of banana looks like, what a one slice of watermelon looks like, and one slice of a mango looks like. But also other savings like rice, the milk powder, glass of whole milk. So these are standard portions or standard serving sizes for different foods. Just had to keep it here so that you can have a picture in your head. So meal exchange distribution. This is done after calculating the exchanges that meet patients' energy prescriptions. Should be realistic. What you prescribe should be something that is realistic and can be reached by your patient. Match with medication regimes for some complicated cases like diabetes with CKD. But also distribution should allow resting of the GI. You should not provide meals like every 2 hours, and large meals. If you provide a short time range between meals, this means your meals should be smaller meals, right? But also you should give the time for the GI to rest, but also include snacks where applicable. The distribution points can range from early morning snack to late night snack. So, for example, for me, I used to plan my diets according to breakfast, mid-morning snack, lunch, afternoon snack, and dinner. 5 meals for my patient, according to how far they can eat or enjoy the meals. But these calculations will really match with their requirements per day. So as a dietitian, you should be able to develop servings for your patients according to their requirements, and that they meet the protein requirement, sodium requirement, phosphorus requirement, potassium requirements, and all other nutrients requirements per day. The final output on the part of meal prescription, consider food availability and accessibility. Consider the food allergy and intolerance. They should be assessed in the dietary assessment part, but also consider food consistency according to feeding route and patient condition. Some patients are on enteral formulas. Some patients feed maybe a full liquid diet. Some patients feed soft mechanical diet or regular diet. So it matters with the condition of your patient. Refer your goals and objectives as you prescribe a meal. Be creative in meal planning. You should always be innovative and creative. So let us see this case study overview as a matter of time. We have this patient X, a man 55 years old male, diagnosed with CKD stage 3A with EGFR of 50. The main cause of this is hypertension. He's on losartan, calcium carbonate, 500 milligrams twice daily. With the anthropometrics, I've not provided a lot of information here. We have the weight, 70 kg, BMI, 26, of which is overweight. The labs, potassium is high, 5.1, phosphorus, 4.5, and the symptoms mainly for this patient are fatigue and mild swelling. So understanding patient X CKD. This patient is on CKD stage 3A. This is a mild, moderate kidney damage. Causes hypertension of which strains the kidneys. The risk is hyperkalemia, hypophosphatemia, and fluid retention. Our goal is to slow the progression, reduce symptoms, but also our approach will be a targeted diet and medication. So now applying the standard operating procedures, just as how we moved with our presentation. Specific requirements. Protein will be 0.8 grams per kg per day, of which will provide 56 grams per day. Sodium limiting at 1,500 milligrams per day. Potassium at 2,500 milligrams per day. This is the dietary potassium. Phosphorus 800 milligrams per day. Fluid 1.5 liters. Energy 30 kilocalories per day per kg per day. And carbohydrates 55% of the daily calories, while fats being 70 grams per day, of which is 30% of the daily calories. So monitoring the labs and weight is very important in this patient as per standard operating procedures. Considering drug-nutrient interaction. Losartan, it raises the potassium level, so we should avoid high potassium foods like avocados, but also calcium carbonate. This is a phosphate binder. It should be taken with meals and limit beans and milk. But also counseling should be done on selection of low potassium foods, but also aligning binders with meals. So now we go to the diet planning, and this is after having all these calculations. We have on starch daily exchanges 15 grams of carbs. We have 7 exchanges of starch, of which one starch serving provides 15 grams of carbs, 3 grams of protein, and 80 kilocalories, having 7 exchanges. We have 3 exchanges of vegetables, in which one vegetable serving provides 5 grams of carbs, 2 grams of protein, and 25 kilocalories. We have 2 exchanges of fruits, in which one fruit serving provides 15 grams of carbs. And in protein servings, we have 5 exchanges, 7 grams of protein, which provide 35 to 55 kilocalories per serving of a protein. And also, while considering the fats, but also we have the fat servings for exchanges. So now, coming to this part of providing this meal plan, we have breakfast, lunch, snack, and dinner. So we can see the four meals. Well, on the breakfast we have 250 ml of cinnamon tea. This is 1 cup with 1 egg white. Why egg white? Trying to limit the phosphorus content in the body, but also 2 slices of white bread, still considering the phosphorus being low, and half cucumber salad and 1 teaspoon of margarine. Lunchtime we have 250 ml cup of ugali, a skinless chicken breast cooked with vegetables, and 1 small pea. In the snack we have 1 small pea and 1 cup of vegetable salad. But also in the evening we have 2 smashed potatoes, of which you can see that these potatoes are a bit high in potassium, but what we have considered are the servings that this person really needs per day, and the potassium limits, but also considering the likes or the appetite of the patient, what food they like and what foods they may need in the diet, and we can associate them in the diet while limiting the potassium, phosphorus, calcium, and everything at normal levels. 2 boiled eggs, of which still considering the egg white part, half cup of steamed vegetables, and half cup of salad, 1 teaspoon of salad dressings. So you can have a picture of what this patient is really having in a day. It is a beautiful meal plan that meets the daily requirements of this patient as per the stage that this patient is on. So, as the last part, how do you do your follow-up as a health profession, as a nutritionist, or as a dietitian? How do you do your follow-up? I would like to know your hints in this in the comment section part. Yeah. So our references are from National Institute of Diabetes and Digestive and Kidney Diseases. We have different papers, Kidoki, and different researches. All of those are part of this, the knowledge that was written in this session and discussed. So let's discuss in the comment section, share this presentation so that your colleagues can also have it. And you can also go through other videos in this channel, whereby you'll also find the case studies in the kidney management or for patients on dialysis, the standard operating procedures in chronic kidney diseases, and other more presentations on dietetics. So thank you very much. We're with me, dietitian Gilbert Gaston Charles, a clinical dietitian, and I'm available through that contact there on the slides and the email gilbertgaston25@gmail.com. So drop your views, comments. Don't forget the points of discussions that we came across in this presentation, and share your ideas on the comment section part. Thank you very much. Have a good time.